In just a few seconds, we're going to meet Dr. Christina Doe. Hello, everyone. Welcome to Doc Talks. Today we have a special guest, Dr. Christina Doe. I don't know if you guys could hear that. Right outside my window, there was a car accident. Well, that's not the way we want to normally start a talk, but today we're going to listen to tips and preventative health concepts with one of my favorite specialists. I always use her as my 911 when I need a second opinion about a dental question. Her name is Dr. Christina Doe, and we are live, so we welcome any questions you might have. I'm going to give you guys a little background about Dr. Doe and ask for questions as we go through 7 highlighted topics that come to me quite often when I see patients in my office. You'll see them as streaming through the bottom of the screen. Actually, I'm going to open this up so you can actually see us. I'm using a very new platform, so I apologize if this is a little bit held up. So here we are. This is Dr. Christina Doe. She is a graduate of Loma Linda University of Dentistry. She's a master of dental laser surgery in dentistry. The technology that she uses, she lectures on worldwide, and people often refer to her when they're looking at new applications of their lasers. She is on an executive board for the Coleman Research Group. She's created her own animated children's educational DVD called Tooth Tales. She's been featured numerous times on the show The Doctors, and she's performed various dental procedures for them. She's published in PBS, American Health Journal, educational videos, and multiple dental magazines. For Dr. Doe, I know that dentistry is truly a passion of hers, and it started in her college days at UCSD. She was inspired by a homeless woman who had no access to dental care. And from that point forward, Dr. Doe knew that she had a calling to perform dentistry to the underprivileged in her community and to the citizens of other countries. Since 2000, she has served in various countries, including Mexico, Peru, Bolivia, Guatemala, Honduras, Papua New Guinea, and Haiti. I have to say, since I've known her, before the pandemic, she was often traveling on medical mission trips, and I've appreciated learning so much about her through our new friendship. Our friendship began because I actually had a colleague who used, I'll wait till this passes, a colleague and friend who was friends with Dr. Doe, and as I started referring more and more patients to her, I found just the most true, sincere appreciation and feedback that she was someone to trust. So I have sent her plenty of frenulectomies, including she did my own daughter's. Sorry, I'm getting myself caught in finding my camera. And so I've asked her to be a resource for us today to talk about some of the common questions that I get in my office. Doc Talks is focused, sorry, as I focus myself. Doc Talks is focused on bringing you preventative health tips that you can apply in your home. I have at least an hour with my patients because I'm a concierge pediatrician, but most people are not afforded that luxury with their doctor. So I'm trying to bring my favorite specialists to you. I'm so sorry about this camera. So, Dr. Doe, we are going to start with, do you want to share anything about you? I know that people can find you at Smiles for OC, and I'll list that at the end. She practices in Costa Mesa. Is there anything I missed? She is also the mother of a beautiful, beautiful 2-year-old boy, and her husband happens to be a dentist. So I'm curious if you guys have lots of dental discussion at home.
No, we don't talk about dentistry at home. Our main goal in dentistry is to brush and floss our own teeth and make it enjoyable for our 2-year-old son. So we don't really talk too much about dentistry.
Okay.
But yeah, it's okay.
Okay.
But I'm honored to be here today, and I definitely hope everyone, learns a lot today. And, dentistry is a passion of mine, and preventative dentistry is also a great passion of mine. So it's great that we together, Dr. Vivi and I, can share what we love the best is just taking care of our patients, our pediatric patients. My specialty, as she spoke, was basically laser dentistry, but I'm pretty much a family dentist. So, I love treating kids from when they were born all the way until treating their great grandparents. So we're just so happy to be here today, Dr. Vivi and I, to share everything that we know together.
Great. So let's start with some of the most difficult but mundane of topics. How do we get our kids to floss and brush their teeth? Anyone who has a toddler in the house knows it's one of the unwanted chores and tasks morning and night. So I wanted Dr. Doe to give us any tips that she knows of, and she asked me to share a few pictures, so I'm going to pull those up right now.
Yeah, so I've been practicing dentistry for about over a decade now. And, before we would do a consultation with parents and then see their little children and then talk about brushing and flossing. Very, very matter of factly. And then 2 years ago, I had my own child and it just opened a whole new world for me. So now, on top of being the clinician who advises parents on how to take care of their kids, I was thrown into the throngs of it. So I've picked up a lot of different tips, but mainly like our goal for taking care of our kids' teeth is just to make sure we set them for the precedence of great dental oral health for their entire life. Making sure that when we introduce the toothbrush, and we really, really would want to introduce that toothbrush the minute you see a tooth pop up. So there's multiple toothbrushes that you can use to make this toothbrushing time very enjoyable. There is not one toothbrush that is the best for your child. It's whichever one they like. And I would start with one, utilize that until they're not really interested in brushing anymore, and move on to another one. When you first see the first tooth that pops up, usually at the bottom in the front, you use like a small little toothbrush, one that your child can hold. They have the banana brushes, they have the infant brushes, the finger brushes. The minute you see a tooth, you start brushing those teeth. If you're an even more motivated parent and you want to start introducing items into their mouths early, they have gauze spiffy wipes that you can wipe down their gum tissue. So the sooner, the earlier you introduce anything into your child's mouth, they will start to accept toothbrushing time as something enjoyable and a part of the routine. Of course, as a parent, we know that doesn't always,
Whoops.
every night's not always going to be wonderful, but you have different things that you can introduce. So, for example, changing the toothbrush, making it a part of a nightly routine next to something that they enjoy, such as bath time, or having a toy that they really like. Definitely positive reinforcement is something that you really, really want to introduce to them. Everything we do should be positively reinforced. Like brushing your teeth, you're very well rewarded for it. Introducing toothpaste, before the age of 2, we have non-fluoridated toothpaste with, great flavors that they can try out. So, it becomes a part of something that they love to do. Also, kids love, their stuffed animals, or they love their siblings. So with their stuffed animals, you can brush their stuffed animals' teeth. With their siblings and with mom and dad, you can have them mimic the way mom and dad brushes their teeth, or do it as a whole team with their siblings, and all brush together as family time. So there's lots of different ways. Of course, there are days when your child doesn't want to brush their teeth, so you have to do different tactics. My child screams, my child cries, but honestly, I still brush his teeth, and we sing songs, we count down, and I know he's not in pain. I just know today is not one of the days he wants to do it. But unfortunately, if you don't make it a part of their routine, they may get cavities, and cavities are a whole new gamut of problems. So, you just every day kids all the time do not want to do anything. We can impart to make it a really fun experience for them. And, on the days that they don't want to, then you lie them down, you have them open, and you just brush. And when they cry, it opens up their mouth, and there you go. But you get all that food out, and, at
Yeah.
least you feel good about putting them to sleep
Yeah.
without food and milk and bacteria and plaque inside their mouth.
So I just want to emphasize that we need to start this process when the first tooth erupts, if not before.
Yes. Yeah. So, I know the first 3 months are very difficult for moms and parents. And so, you get a little window of a break, but if you can start imparting like wipes, soft little hand cloths just to wipe the gums down, you get extra credit. But it does make your life easier. Anything you introduce earlier in life makes it that much easier later in life.
I'm going to take off the Philips Sonicare, but I want to mention that because I know the difference between using electric. So I'm trying to figure out where I am in my camera. Electric versus the regular standard toothbrush. This is something I introduced very early on, and children do complain, adults complain of sore gums that last about a week once you start these toothbrushes. So you want to start them mild and then continue. And we do rotate between toothbrushes, but this one happens to do the best job at keeping their teeth clean. So we went through phases where she loved grabbing the toothbrush because she saw her big brother doing it, but then now I actually have to wait for her to cry so I can get her teeth done. And it's a fake cry. You have to just know it's a fake cry. Some days are much better than others. Elmo sings, putting that on, and they see other kids brushing their teeth and how fun it is, and songs. It's just about distraction, getting it done. And flossing too is really important, right, Dr. Doe?
Flossing is really important because unfortunately we can't really take x-rays until about 4 years. And so you'll get cavities in between the teeth and no one will ever be able to see it. So I'm okay if you don't start introducing flossing until around age 2, when their back molars start to touch, because you don't get your true second back molars till 2.5 years. But if you start flossing earlier and you get to floss the front teeth, it's so much easier than waiting for the back ones. They have flossers for kids. So you introduce that, it's fun for them, and it's much easier the sooner you get that in. As both parents, Vivi and I know how, Dr. Vivi and I know how busy we can get. But, if you just introduce that earlier, then eventually you move that flosser to the back, less resistance you'll get.
Yeah, it's about introducing them. The Crayola ones have a nice flavor, a berry flavor. The kids love that.
Yes.
They're not sharp and pointed. You can use the sharp one as well. I'm getting some comments that you're not on the screen again, but I do see you.
Yeah, I see myself.
I took you up just to highlight the toothbrush, the Sonicare, which I will take off. Maybe if I take that off. There we go.
But they can still hear me?
Yeah. And
okay.
you're on, I'm showing it live on my Facebook feed, and it looks like you're on there. So I did take you off for just 2 minutes.
Okay.
So
real quick though, one thing I do want to add is you do want to switch your toothbrushes every 3 months. And then also if your child is sick, then throw away the toothbrushes that you've been using. Toothbrushes unfortunately are a big bacteria harboring.
We see that with strep throat. I mean, you can't really tell with some of the other things, but strep throat will come back 24 hours after you've been on amoxicillin. You got to toss that toothbrush.
Yeah, you have to. Yeah, and then there's a new toothbrush called the Auto Buddy or Auto Brush that it's like a tray that you put in your mouth and turn it on. And it's pretty expensive. It's $100, but it does not show the true effect of brushing teeth one by one. So I've had a lot of parents ask about that. It's a newer, like Shark Tank type of item that's out on the market.
I've seen it advertised,
Okay.
actually. I
Yeah.
remember that.
Yeah. So I would be pretty
Hesitant.
about utilizing that, because then you might cripple your child from brushing correctly as they age. So
I'll put that in the comments when we finish the talk.
Okay.
So people can refer back to, yeah.
Okay.
And then someone's also asking for links for the flossers.
Okay.
And I'll put those in. At least
Okay.
I like the Crayola ones. You can find those on Amazon.
Yeah, the Crayola ones are the best because the picks at the end are not sharp the way the adult ones are.
Correct.
So, and then they have reach flossers, which have a long handle for parents to hold on to.
Okay.
So they can get to the back.
So I'll just put a little Crayola and reach flossers.
And then one thing that I noticed too, when we use those type of flossers, when you floss from tooth to tooth, you have to wipe off or rinse before you move to the next tooth. Otherwise, you're moving bacteria from one tooth to the other. So I think a lot of people forget that.
I don't know why, but my husband started, and I wish he would watch this, reusing the flossing sticks. I was just, and you know how cheap they are. He doesn't waste anything, but that is really not a good idea at all, right? Because he'll rinse it and leave it at the side of the sink. Just from everything I know about bacteria and tooth decay, it would just be a potential for bringing bacteria in between the teeth, correct?
Yes. So ideally you can use one flosser per day, but rinsing it in between each.
Oh, you know what? He probably learned that from Dr. Wu, because he would not do that on his own. So he's probably using the one in the morning, in the evening after he rinses it.
Oh, okay. And then tossing, because they're not meant to be reused.
Yes.
Se.
Okay.
Yeah.
Thank you for clarifying that. I'm glad it came up.
Okay.
Let's see. Okay, we got through those questions. Let's move on to the next topic. So the fluoride. Now, there's nothing that we love more as doctors and dentists than the realization that fluoride will prevent cavities. So I'm wondering, you hear the same thing I do, and then some, about people's fear that fluoride's dangerous or damaging. Can you speak to what the positives, and if you know of any negatives?
So definitely, if you think about it, on a daily basis, we give our children and ourselves vitamins. So if you think about it, how can you not get cavities? So the only thing, honestly, that we can potentially protect ourselves is through fluoride, and not a lot of fluoride, right? Everything in moderation. So we brush our teeth 2 times a day with fluoridated toothpaste. Really, nobody drinks tap water anymore, and that does have fluoride. And so, the communities were hoping you would drink tap water and have some form of protection for your teeth. So honestly, I'd probably say 90% of our world doesn't do that, or of our community really doesn't do that. So then really the only protection we have is the fluoride from our toothpaste, and maybe fluoride from when you visit your dentist. So think of fluoride. It's not an evil thing, quite honestly. People think it's a medication, people think it's a toxin, but at the end of the day, fluoride is a mineral that's naturally occurring, and it's virtually the only vitamin that you can possibly give to your teeth. So of course, if you ingest like a whole tube of toothpaste in one sitting, you'll probably get a tummy ache, right? I mean, it's not meant to be eaten in that regard. But yes, if you give some to your child and a little smear of it onto the toothbrush, not a pea size, until they're able to spit out, then that's enough to help prevent decay in the mouth. Because anytime you eat food turns into plaque. Plaque is very acidic, and it adheres to your teeth like barnacles. And then now it slowly starts to secrete acid onto your teeth. So now think of it. If your child doesn't let you brush properly, you're never going to get that white, fluffy stuff off your child's teeth. And then that acid is going to start burning into your child's tooth. So if you can't brush it off, then then the only other thing you can do is, if you introduce fluoride from like a prior toothbrushing time, or the fact that it has properties from when you introduced it, the acid gets neutralized by the fluoride, which means that now the acid that's burning into your teeth is blocked by the fluoride that you had introduced from maybe the night before when you were able to brush your child's teeth properly. So what you can do if you know for sure that you're an amazing brusher and can get every single piece of plaque off of your child's teeth, then maybe there's no acid and maybe you can get away with not giving any fluoride to your child. I'm not saying you need to give fluoride supplements. I don't recommend fluoride supplements by any means. Fluoride rinse is okay once your child can spit. But at least, you know, for me and my husband, we want to give our son protection because, you know, there are days when, you know, he eats sticky stuff and we just can't get in there as best as we can, even though we're fighting him to brush well. But at least we know we've dispelled a smear layer of toothpaste onto his toothbrush to help him combat the acidity that gets introduced from all the food that he eats. And so the process of fluoridation is called remineralization to get the teeth enamel stronger. So plaque when it appears, it can't eat as easily. Or demineralization when the tooth turns white because the acidity that burns into the tooth, turning the teeth white. So we see a lot of white spots on children. And that is because, unfortunately, we've left acid. It burns holes into their teeth. And the fluoride toothpaste that you've introduced can help redirect that and harden the enamel again. So honestly, if you use fluoride in moderation, you're going to get great help for your teeth that will keep your teeth healthy for the rest of your life because now you haven't introduced that bacteria that causes cavities into your saliva flora.
Got it. Thank you so much for that explanation. And I'll tell everyone out there that there's always been a push in the pediatric office for dental health and fluoride treatments for the underserved communities. I have always recommended using a Brita filter because of the wonderful minerals that are in water that you can still be providing yourself if you drink tap water that is somewhat purified from impurities. But fluoride, like many things that people fear, are going to be found in soy milk, almond milk, everything else that you eat. So there shouldn't be a fear when it comes to a recommendation for a fluoride treatment at the dentist and the dental office.
Yeah, it's just, you know, preparing your child's teeth for a better future. And we only utilize a small amount that's completely safe. So, you know, kids will always eat things that we don't want them to eat. And then foods always turn into carbohydrates, into sugars into acid. So you really need some form of protection for your teeth.
And I want to mention that for children who have reflux, there is an issue with the acid that does destroy the teeth, especially if you grow up having the reflux. And it's not ideal, correct, to be brushing right after you have a reflux event that can be damaging to the teeth. Is that right?
That's correct. So unfortunately, acidity is very detrimental to our teeth. And so you do want some time for your basic saliva because the pH is so acidic from the acid that comes from your gut. You want the salivary flow of the basicity of your mouth to kind of start coating over your teeth. So they do say to wait half an hour before you start brushing.
And that's true. That would be true with someone who's vomiting, who's sick.
Yeah.
Maybe rinse your mouth with some water and then wait a little bit and then brush.
Yeah. But you still definitely have to brush after because otherwise you're leaving so much acid in your salivary flora that now you're going to start having a lot of teeth problems.
Got it.
Yeah.
Okay. I don't see any other questions. Let me see if there's a way to go. If I mute this, I'm going to see what happens.
Acid in your salivary flora.
Okay, good. All right. So the next topic that we have is cavities in primary teeth and why even care. This didn't even cross my mind as a question until a parent said, they're going to lose them anyways, right? I mean, they have a few cavities, but what do I care? Or why am I going to spend all this time fighting my child to brush? And I have to say the coincidence that heart health awareness and pediatric dental health awareness are in the same month is so important to me for that question. We know that there's seeding of bacteria into our bloodstream from our mouth, and the cavities are a source of that through studies have shown. So especially if somebody with any type of abnormal heart valve or what we call holes in the heart, just between the ventricles, these are a source of clots that can seed through the body, bacterial clots. So I'd love for you to speak. Here, let me speak to brushing and caring and taking care of cavities in our primary teeth.
Okay. So think about it like this. When your child's born, everyone starts with a clean slate, right? You don't have diseases, you don't have bacteria, you don't have, little viruses in your system per se. Now, when you start introducing, foods and things like that, you start to get cavities. So, and then the cavities are caused by different types of bacteria called Streptococcus, and there's a whole slew of them. So if you think about it, when you start with 0 bacteria inside your mouth, now you have you're introducing all this bacterial flora. And then first you start with 1 cavity, then you start with 2. And so now you leave those cavities inside your mouth, you don't treat them. Bacteria, what it does is it proliferates. Once it proliferates, now you're introducing more bacteria into your saliva. Now, when you're in your 10-year-old, 11-year-old, now you have way more bacteria that causes cavities in your system than you did when you were born. Now you have adult teeth. So once you get adult teeth, all this new bacteria that you introduced into your salivary flora starts eating away your adult teeth. So your baby teeth basically give you a precedence and a precursor to what your adult teeth will look like. If you have 3 cavities in your baby teeth, which out of 20, you're going to have, think of it, you're going to multiply infinitively to having more cavities in your adult teeth. And you're right, you're not going to lose your adult teeth. So then you're going to be fixing them basically for the rest of your life. And then also, small cavities lead to large cavities. Large cavities lead to root canals, baby root canals. Baby root canals lead to crowns. Crowns lead to extractions. Now, you need to keep your baby teeth until at least 12 years of age. Now you have all these baby teeth that have been extracted prematurely. You have no landscape for your jaw to form anymore. So as you're losing teeth, then adult teeth come in, they can't figure out where to go because you lose a tooth, the adult tooth is below it. It's supposed to come up straight. But if you have all these missing teeth, when adult teeth come up, they'll come up wherever they feel like because they don't have the proper placement of following the eruption pattern of where the baby teeth are. So, and your jaw does start to shrink, your palate and your lower jaw shrinks because those teeth are no longer placeholders, those baby teeth that you've pulled out because of all the cavities. So, cavities at 3 years old are going to be extractions by probably 6 years old or 7 years old. And so then when your adult teeth comes in, it's going to come in wherever it feels like, and then your jaw is going to shrink, and now you're going to be left with a very shrunken palatal arch and a shrunken arch on the bottom. So then it's going to change your whole entire landscape of how your face is. So if you were going to have a nice rounded arch and then your face was going to be nice and rounded, now it's going to be shrunken in with teeth that are mismatched and crooked. And then now you're going to be in orthodontics. You're going to have to do expansion. You might have to do jaw surgery. It's a whole domino effect, quite honestly. So
important to hear you say this.
Yeah.
I mean, I know it's important to brush the teeth, and I know it's important to see the dentist to take care of cavities, but especially during the pandemic, it's been so easy to say, well, we're brushing. We don't need to go see the dentist.
Yeah.
But wow, so interesting. Thank you.
Yeah.
Really, you explained it perfectly.
Yeah, it's very important. I mean, it builds the landscape for your entire adulthood. So,
Sure.
so it's
Sure.
so much easier to fix a small, tiny cavity than waiting for it to fall out. Because honestly, your child will probably be in too much pain to wait until it falls out. So those premature things that you do cost them into their adulthood.
Okay. So really quick, some questions that have popped up. One is, and I don't think I'm looking at our other. So I think we'll just talk about it now. Underbite in a 5-year-old.
Okay.
Whenever she's smiling, her bottom teeth are always in front. Do you want to talk about this when we talk about passies and bottles, or?
No, we can talk about it now.
Okay.
So the great news is her daughter is only 5. 5 is beautiful because 5 means she's growing still. So what we would do is usually we do start seeing an orthodontist these days around ages 6 to 8. 8 years is usually for those who have nice spacing of their teeth, not a lot of crowding. But 6 is a great time to start in the sense when we start seeing an underbite or we see too much gum tissue or the bite is too deep. Anything that looks like occlusion, where occlusion is going to be a problem, where your top teeth come together to your bottom teeth. If that's a problem, we start with orthodontics early because we can do expanders. We can do, so basically an expander will expand your lower jaw, expand your upper jaw, and correct your bite without waiting until it's too late where you have to do jaw surgery.
Can I interrupt you? You're saying orthodontist visits will usually start around 6, 7 years of age, and then someone like this might need to go early before then, or not wait.
So early would be 6 years because you do want the 6-year molars to have erupted. And then if you have an underbite, you'd go after you see those 6-year molars come through, because then that's when the orthodontist can do something.
So I think the point is, the question is, her dentist would guide her, but she shouldn't expect to go before 6 years. If there's something going on with bite, we still wait till 6 or 7, 6.
Because we do need the molars.
Okay.
There are other appliances that you can use before age 6, but they're harder to use because they deal with patient compliance. So you can put mouth guards and mouthpieces into a child's mouth earlier than 6, but they can reach in and pull it out. Nice. When you're 6, the orthodontist can place permanent expanders inside the mouth, and the child can't take it out.
Got it.
So unless you know your child will be completely compliant with these mouthpieces, then yes, you can have intervention earlier. But honestly, the compliance on that is like 5%. It's very, very low. And it's an appliance that is on the top and the bottom that they hold inside their mouth while they sleep. So
now, is there a way that a parent can prevent such a underbite or overbite if they weren't doing anything but pacifiers? I know mouth breathing at night. I'm very proactive asking my patients, is your child breathing with their mouth open at night because of tonsils and adenoids, and how that can shape the mouth differently?
Yes.
What would you say about prevention? How could someone pick up on signs early that this might happen?
Well, certainly certain things like pacifying, thumb sucking, putting fist objects inside the mouth, tongue thrusting, lip ties. So a lot of those things should be checked when they're younger. And then if all those things have reached normal limits, then potentially the underbite, if it's a skeletal concern, that's when the orthodontics will come in. So some children could have prevented it, but some people it's genetic. And so if both their parents have underbites and their grandparents had underbites, then most likely early intervention would be awesome for the child. But yes, those other factors, if she was tongue thrusting and pacifying and thumb sucking, would probably make it worse. Okay.
And we'll talk about passies because I have some questions about that.
Okay.
She thanks you. She's
okay.
very grateful.
You're welcome.
This is awesome learning for me too. Okay, this is my favorite question. So how often or ever have you seen someone come to you with pediatric, I think adults, it happens more with big procedures.
Mhm.
How many times would you say that someone's recommended cavities, fillings, or some sort of orthodonture procedure? I'm not sure if you comment on orthodonture when they come see you, but would you say that a second opinion, if it's going to be something invasive, is worthwhile in the pediatric population? In Orange County, we're not like a rural community. But do we just assume that you're getting a good opinion if they're well versed in pediatric or dental care, or is it
Mhm.
worth getting a second opinion sometimes, and when?
So I would say whoever your clinician is in all regards, dermatology, concierge pediatrician, dentistry, physical therapy, if you go somewhere and you're not comfortable, then a second opinion, I think, is substantial, because you want to trust who your clinician is. And you want to make sure, you have a good working relationship with who is treating your health. So, honestly, I like the way, honestly, how my office runs things. We do a consultation and we give our, concerns, our opinions, our advice. And then the parent or patient goes home and thinks about it.
Mhm,
We never do treatment that day
mhm,
because I think it's important that it's like an interview, the parent child interviews us and we interview the patient. And it should be a relationship where, when you start somewhere, you're comfortable there, you trust them, and then you continue forth. Um, I do see second opinions in the pediatric world because a lot of it comes up with, oh, your child has a couple cavities. They need to be general anesthesia sedated. And that's a big thing for a parent to swallow, because
yeah.
number one, they probably didn't think that having a cavity was that big of a deal per se.
Mhm,
And then all of a sudden, someone's recommending, let's put your child to sleep and fix everything.
yeah.
So I think that's valid, because putting a child to sleep is scary. Putting anybody to sleep is scary. And we're lucky that we do have amazing anesthesiologists who can safely take care of us. But if it brings up warning signs, makes you and your family uncomfortable, there's nothing wrong, I think, about getting a second opinion.
Okay, good.
And then also, dentists do practice differently. Some are more preventative, and some are more aggressive, and some take a more conservative route. So, like if you are a friend who is conservative with decision making, sometimes you get along better with friends who make more conservative decisions versus someone who might just hop on a plane and go somewhere so quickly. Um, so you
Such good advice, yeah.
so you might develop a better relationship with someone else. And there's never any hard feelings because at the end of the day, every clinician is trying to take the best care of the patient before them. But it's still very important that the parent or the patient gets the best results and they're comfortable with it. So I think we're always asking for second opinions from friends and family about,
Everything, yeah.
everything. And so I don't think it's a big deal if a parent feels uncomfortable or just curious to get a
Mhm.
second opinion. Because honestly, I've had a lot of parents who've come in to see me for second opinions about sedation. And, luckily and gratefully, I have a dental laser where I can do no shot, no anesthesia, one by one fillings for children, but it's going to take longer. I only do one cavity at a time for a child versus if you sedate your child, you can get all 10 done. But I mean, we've been, have parents who've been very patient. They bring their child one by one, but then in the end, they don't have to have them sedated. So it's a matter of preference, what
Yeah.
the parent is most comfortable with.
So in surgical procedures, medical surgical procedures, it's no different. We do want people to feel comfortable with the decision to go forward and want them
Mhm.
to get the second opinion. A good surgeon would always ask that if they get a second opinion to go ahead and share that with them and come back if they're comfortable. So
Mhm.
it sounds like it's exactly the same with even cavities if they have to
Yes.
be sedated.
Yes.
Okay, good. Yeah, I didn't know. I mean, I just assume if they have a cavity, it should be filled. And then once in a while, I hear these stories where it was really questionable. They had to fill 6, 7 cavities. But it's really how the parent feels about their relationship with the doctor.
True. And then also in dentistry, a tooth has three parts. There's the enamel, the dentin, and the pulp. So cavities, you have a cavity if it's in the enamel, but some dentists will do a filling if it's in the enamel and not in the dentin yet. But some dentists will do a filling if it's in the enamel and penetrated into the dentin.
Got it.
So that might be a difference in 5 cavities versus 2.
And then it might become an issue when, when is this tooth going to come out?
Correct.
Are you, 6 or 7 and you're going to lose the tooth and it's not that far? Okay. Got it.
Yeah. So, yesterday I, gave some opinion to a patient. So she had a cavity touching another baby tooth, but it was going to come out in a year. And so, I gave her the option, do you want to extract it or do you want to do a filling? But then if you do a filling, a lot of the tooth was already missing. So there's really nothing below. So, but you don't really want to leave a cavity because then it's going to spread to other areas,
Right.
or introduce more bacteria that causes cavities into their flora. So that could be a different of opinion. And unfortunately, sometimes money plays a factor, like an extraction is cheaper than a filling, different things like that. So that's why if you're uncomfortable, a second opinion, or if you're just curious, a second opinion, there's no downside per se.
Good. All right. So that brings us to our next topic. I'm trying to pull up some of the images, but let me just get back to the new topic is now on, I think we're up to lip and tongue tie. And let me share my screen. You're going to jump off just so I can get the image on the screen, I believe.
Okay.
So we're going to show this. It's just to make it bigger. I'm going to take you off. No, I just going to hide you. And then we're going to do this. There we go. So, yeah, I believe we can still hear you. Go ahead. Oh, shoot. Okay. Shoot. So it sounds like people are not hearing. Okay. Okay, I'm gonna show you in stream. Let's see. All right, so we're gonna do a little recap because it sounds like people could not hear my guest, and she's talking about.
Can you hear me now?
Yeah, I think it was that you were hidden.
Okay.
So go ahead, and why don't you summarize? These are the you can do a quick summary for us.
Oh, okay. So what we're showing here is basically the 4 different classifications of lip tie. And what I said before is basically I didn't realize how important lip ties and tongue ties are until I started delving deep into understanding this area because 2 years ago when I delivered, I realized, breastfeeding, feeding my son was a huge factor in just his growth and development. And we were very much stifled by the fact that he was tongue-tied. And so now constantly, as our infant and newborns come in, we are constantly looking for this because if a child has classification 2, 3, or 4 of a lip or tongue tie, unfortunately, there is going to be some future problems. And for the current problems, the child's not going to get proper nutrition. The child's going to have to work harder to drink milk, whether it's from the breast or from the bottle. If you really do want to breastfeed, which was, my own prerogative, like it was very painful. And so, and pain leads to, chapping and bleeding and sadness, probably depression, going in and out of lactation offices, also trying to get laser procedures to try to help on the maternal side, because we're always trying to fix the things on our side. But, if a child is lip tied, if a child is tongue tied, you can correct that problem, within 5 minutes, and that will lead them to better eating, better feeding, a whole gamut of great advantages for their future. So currently it's basically no more pain for the mom, no more problems with the latching for the child, no more problems with gassiness for the child, no more problems with milk coming out the sides of their mouth, no more problems with digestion problems, especially like the burping problems or the
Yeah,
it's just so many advantages if you can find someone who diagnoses these lip ties or tongue ties in the early stages. So there's no downside to doing it too early, because it's just going to help you as the parent, whether it's bottle feeding or breastfeeding, and the child doesn't have to work 5 times as hard. Because my son, he was breastfeeding for 5 minutes and falling asleep, and after I clipped his tongue, released his tongue, he could breastfeed for 45 minutes and be full and satiated and then fall asleep.
Yep.
And he wasn't struggling with his weight back then. And so, you just have to make sure, if you start to have any signs of gas or milk spillage or pain to breastfeeding, or not pursing and getting a vacuum seal over the bottle or the breast, you should have someone start to look into that. And then with the tongue tie, you really need to make sure that's not a problem, because that when they drink milk, whether it's from a bottle or a breast, then they need that tongue for that movement of capturing the milk. And a lot of children, they're all survivors. So what will happen is they will work around the problem of being lip or tongue tied, but it just means they have to work that much harder for something that could be just so simple for them. And then if you leave lip and tongue ties, it leads to a whole gamut of problems later in life. I did a tongue tie release yesterday on a 4-year-old because nobody had caught his problems before, and he had speech impediments. He could barely use words because he could barely move his tongue for certain letters. And then within 5 minutes, his tongue, he could touch the roof of his mouth. He could touch his, he just had so much mobility to his tongue. And his mom she cried in my chair because she just couldn't believe how much mobility he could have. And then he started talking more. It was phenomenal to see, quite honestly. And we might not see that immediately for some infants, but just to see a lot of moms being able to breastfeed painlessly is just a life changer. And so I think these lip and tongue ties are very important to catch. And quite honestly, Dr. Beebe is one of the few who really, really do that thorough examination, because my pediatrician honestly didn't say a word to me. And even when I told her I released my son's tongue, she was kind of like, oh, okay. It didn't even require a conversation for her.
So a couple of comments. We have about 12 minutes remaining, but this is such a great topic because until I was doing concierge, well, I've always spent a lot of time with my patients, but parents now, with the reason I'm doing these shows is to correct misinformation, but there's something about the internet that has brought to light this growing group of infants and newborns who have tongue tie. And honestly, I think a lot of pediatricians think this is from a mom blog, this is bogus, there's just too much of it. So I have delved deep into it. I was able to work with a lactation consultant in my office for many years, and then started giving her lectures when she was sick, and started looking at latching. And because I do the concierge practice, I spend an hour to 2 hours on average in my office, especially with newborns and infants. So the latch is so important because, like Dr. Doe said, growth in the first year of life is so paramount as an indicator for good health. I can't believe how many times I'm seeing some strange air gaps or things that cue to me that something's not right. And then I look and there's a huge tie right here, just so tight. And at that point, I look and I think, oh gosh. And Dr. Doe also has had the unique experience of working closely with me since she does the laser surgery without needing any sedation and is local and available to consult without a fee. And so I've been, I stopped myself after a year because so many of my patients were going, and even my daughter, and I thought, oh my God, what is going on? I have talked to a couple dental laser surgeons, and they have explained to me, yes, this is actually maybe 40 to 50% of the population with ties. And one thing we know is, look at the human body's not perfect. There's plenty of people flat-footed. At a certain age, we put an orthotic in so that they don't have hip problems and other functional anatomy issues. So cutting the lip is not that invasive if you're using a laser and it heals. So I was one of those hesitant parents. My daughter was always at the 100th percentiles. Was there really a reason to do anything? And I pressed Dr. Doe, and she said, you can wait because a procedure is a procedure. And in medicine, we don't want to do anything harmful. But at 1 year, a little over 1 year, we did it. We were in and out, and the holding was painful. But yes, also she's moving her lips. She did look a little different, and I had heard that from patients. But we probably waited too long because she has a big space between her teeth. So I'm going to show the next image, and you can speak to that. How if you leave it, how sometimes you do get these other issues, right?
You do, yeah. And I did see a question there, but so just
you can speak to the question while I pull it up, or whatever, however you want to manage it.
So it is true. At some point, if you didn't release them with a lip or a tongue tie, then maybe it won't cause a problem. However, if it's a lip tie that is left when they're older and is suggested to release it upward, is for the fact of helping the two front middle teeth. So it's called that space, it's called a diastema. So when a tie is too low to the teeth, when you speak, you start to see everything pull upward. When everything pulls upward, the two teeth in the middle, they separate. And so with orthodontics, you move it back together, but if you don't release that tie, then it opens up again. So it's constantly going to be fighting back and forth, back and forth. And then if that lip, whenever you talk, it keeps pulling up and down, you're going to get gum tissue recession, where the papilla that nicely protects your teeth now gets pulled upward. With aging, our gums always get pulled upwards, but now it's going to get pulled upward at an exponential rate. So, it depends on why the clinician suggested the lip release at age 14 as to the question. But there are reasons as to why you would do it later in life if it wasn't caught earlier. And so unless, maybe a child does like a gap in between the teeth, but now they're going to get recession. And recession leads to basically bone loss. Because if your gums recede, the bone recedes too. So if the bone recedes, then the gum recedes. Eventually, your tooth is only protected by 3 walls of bone. And then when you're older, your tooth just falls right out in front. And so recession is very bad because it makes you get bone loss. And, as dentists, we're definitely trained to do frenectomies. A lot of dentists do not, because when we were trained on the scalpel technique, which is a lot of medical doctors do. And so nobody really wanted to, because, it's not a really fun procedure when there's like sutures and shots and bleeding. But the reason why I do them is because I use my dental laser, where I don't have to give a shot. I just use topical, and there's no sutures involved. And then when you use a scalpel, you can get a chance of reattachment. With the laser, you don't have that, because if you're using scissors or a scalpel, your body thinks it just got hurt. But when you're using a laser, it cauterizes it and it doesn't allow it to reattach the way a scalpel or scissor would. And I think maybe now we're noticing more frenectomy or lip ties and tongue ties because we're looking for them more. Before, I mean, one of my colleagues who's older said, "Oh, I don't know how to do them, so I don't even bother looking." So,
Yeah, there's actually a comment here that one of the listeners had to go to a special doctor and wasn't allowed in the room during the procedure, and that's really traumatic.
yeah.
Not all dentists do them. Some pediatricians are trained to do them actually, but I've seen them bleed so massively that I don't want to take on that responsibility.
Because if you use a scalpel or scissors, it's like, getting hurt at home. So you have, so I'm sure a lot of people don't want to do that because it's not very pretty. But luckily, I mean, I'm comfortable.
We share a patient that it's unfortunately sometimes the first time we find that there's a bleeding disorder.
Yeah.
So it's again the reason that we don't want to. I don't want to do it in my office.
Yeah, exactly. So luckily the laser can cauterize, and with a normal patient, clotting disorder is a totally different story. But we can cauterize any bleeding if bleeding becomes a concern. But you don't have to put sutures. I have all my moms breastfeed immediately in the room as part of the procedure, just so they can feel the difference in the initial breastfeeding and then after the tongue tie or after the release ties.
And I can actually attest to the fact that she cried her head off. She was strong. My 1-year-old. She got out of there, was playing. She had the next feed. She ate on the way home. I knew how to stretch the upper lip, and we were doing it. And Dr. Doe left. She's like, I'm like, how is this stretching? She's like, I'm not sure if people even do it. I have seen people who don't do it and it reattaches. So we were aggressive with stretching for the week, and there was no downtime. She ate normal. Everything was great. It was phenomenal. So I do recommend doing it early. I had a baby do it really early because they needed it, and it reattached. But you just said that those are the rare cases, and you go in and do it again, correct?
Yeah. So for babies, if you can do the stretching, obviously that's an added bonus. But for babies, they're constantly using their lips to feed and to cry. And so that in itself is great stretching, And so, a lot of times and you actually have to stretch if you're doing it the traditional way with the scalpel and the scissors. Otherwise, it'll just reattach. You're right. And some that are thicker than the average may reattach. So sometimes you have to do revisions later in life.
And the motivation that I had was, you said that toothbrushing is going to be a pain. She's not going to like the toothbrush going up there. So that's when her teeth came in. I said, okay, it's time. And if you look at this picture that's on the screen, she was, up here in the top left, but she was eating and growing just fine, breastfeeding. She had a little bit of a different type of breastfeed where she would jump off a little bit, but it was time when she was ready to brush her teeth. We do think as pediatricians, same with circumcisions, the earlier you do things, the pain receptors perhaps are not as fully developed. So it's
that
not a
helps
bad
a lot.
idea to do it early.
Yeah.
And then remember,
if you do it early too, they don't have to retrain the way they drink as easily. Yeah, because they had habits from before, because they had to work around the ties. And so if you do it earlier, you're not going to have as much retraining, or they're not going to have to retrain themselves as much. So, and then earlier, you definitely want to get it done earlier before those 2 front teeth come in, because a lot of kids, if they have a low frenulum, they don't want you brushing their teeth, because a lot of times you brush their frenulum too, and it hurts.
So we have a few we'll make these 2 points quick.
Okay.
X-rays, I personally wanted to avoid them.
Okay.
It was a little bit silliness. Thank goodness I'm friends with Dr. Doe, so she could talk me back to reason. Can you explain what the reasoning is for X-rays and why you don't? At what age would you recommend them? And of course, it's going to be dependent on the patient, but I'd love to hear reasons to do them, and can you ever decline them?
So the first thing you have to know is you make sure your dentist has digital radiographs, digital X-rays. That's the only way you should take x-rays digitally,
X-rays.
because
I'm
that
writing
takes down the rads, which is the radiation, like 100 folds. Like usually I don't know the numbers anymore, but basically say it was like 800 rads per x-ray. Now it's only 8. So taking digital x-rays, I mean, honestly, with the recommendations, you don't even need to wear the lead shield if you're taking digital x-rays, but we definitely still use it. We start with a panoramic x-ray at age 4, as long as the patient is able to stand and take it. If not, it's no big deal. We want the experience to be positive and easy for the patient. So then we just push it to the next year. So that shows growth and development. It checks for pathologies. It checks the sinuses. It checks, the condyles. It checks all things that we cannot see clinically and visually. But we do not push x-rays for children if they're not comfortable with them. Now, when I do,
if the parents, you talk the parents through it though, if they don't want them, or are you talking about if the child is having a hard time?
If the child is having a hard time. Now, if the parent doesn't want them, basically, we do ask like the reasons behind it. So say the child comes in at age 7 and the parent doesn't want x-rays. So I do my clinical visual exam, but by now the child has adult teeth. The child has teeth that touch each other. When I do my clinical visual exam, I can't see in between the teeth. And so if I can catch those cavities early, then it's just a little tiny filling. But by the time we can clinically see a tooth that's infected, it's near the nerve. So basically it'll be a root canal. So I don't know if a parent really wants to put their child through a baby root canal and then a crown after it.
And you earlier in this commentary discussed on all that follows after a baby root canal. The sequence of changing in the mouth. Can you hear me?
Oh, yeah. I'm sorry.
Earlier in the show, you already outlined all of the negative effects and the cascade of events that happens if you do have just one baby root canal.
Correct. Yeah. So,
by the way, you're getting a lot of thank yous in our comments here.
Thank you. Yeah. So, I mean, we definitely try to be respectful of x-rays. But at some point, we just, you just can't, it handicaps us from doing our work correctly. Like if you ended up having like an ulcer or like a stomach ache, and there's only so much someone can see, like clinically and visually.
Right.
So, at some point we just, we can't treat our children correctly anymore if it's consistently being declined. So I understand, like, when they're younger in the beginning, but if you have a problem, there's no way to catch it just clinically, visually.
Okay, we're now at 3:00. Do you need to leave?
Oh, no, I'm fine.
Okay. When to discontinue pacifiers and bottles?
Okay, so honestly, that's a big one because parents need those pacifiers. They need those bottles, but it is very detrimental to our children. So I'm fine if a child wants to use it till 2, but it's a hard cutoff at 2, quite honestly. If you want your child to grow correctly the way your child's supposed to. So around age 1.5, I start telling parents maybe you should start like doing positive reinforcements on switching out these pacifiers and bottles, because you're changing the whole entire landscape once again. If you use these pacifiers and bottles beyond age 2. The worst part is, and we see it all the time, basically the tongue thrusts forward into the space that the child has created from the pacifier or the bottle. And then the tongue grows, it gets bigger, and nobody really wants or needs a big tongue. And then they start getting something called an open bite. So when we bite down, we want our top teeth to go perfectly on the bottom, but we don't want this big hole. And so that's unfortunately what a pacifier long-term and bottle does to our patients.
I have a screen of that. Do you want me to share that?
Yeah, that would be awesome.
Let's see if I can find the right one. There were 2 that you sent me. This one.
So the first one was just what it shows for baby teeth. And the second one shows how it follows into your adulthood. So you're creating a very poor landscape for your adult teeth.
So this is the baby. No, this is the adult teeth. Yeah.
This is the adult
This is
teeth.
that hole you're talking about.
Yeah. So this is called your open bite, and your tongue needs to fill the void. And when you speak, you start thrusting your tongue forward because it doesn't have a blockage because there's an open gap right there. So eventually you're going to start spitting more. Your tongue's going to come through that open bite. And then your orthodontist is going to have to do a lot of correction to realign your palate and your lower jaw correctly. So all this can be prevented as long as you stop the pacifier early.
You see that now you can see the spacing issue.
Yeah.
Right?
Yeah. So actually this is different. This is
so you want a different, okay.
yeah, this is if you were good about stopping the pacifier early.
Oh, so that was how you want your teeth to look.
Yeah, that's the more ideal picture.
Okay.
There's
So
one
then
more with like baby teeth, but that's fine. So, I mean, everything is correctable, but how much do you want to correct? So if you nip things early in life, it's going to be so much easier. This is a lot of orthodontics. This is patients who say, oh, I was in orthodontics for 8 years. Oh, I had braces for 10 years, you know, and this is like headgear and I don't know.
I'm picturing 16 candles right now.
Yeah.
Oh boy.
Rubber bands.
Yeah, I've always felt like move right to the orthodontic passies that have the thin center where the bite comes. Kind of like a nubbin on the inside, but still we tend to be happy if a baby can take a pacifier, but usually even by 6 months, I'm trying to get them to wean to like even a blankie that's silky, something to suck on.
Yeah, that's better. You know, but what'll happen is eventually they will figure out, oh, I have my thumb, you know? So a thumb is bad too. Yeah. So as much as you can just start, if kids start putting things in their mouth, just start taking it out earlier. I mean, you can
taking it out early.
Yeah. So you can replace it, substitute it with food. You know, if they really want something.
Because in pediatrics they won't say anything. You know, they're happy. They throw that in the when the baby's born, they give you a passy and try to teach you how to use it. And I've always been baffled by that. It doesn't make any sense. It's nice for babies to self-soothe. But you know, they should be able to do it without the passy.
You know what though? What I realized though is the passy does play a pretty good role in the beginning of their early life because it helps them with sensory. And that tactile sensation of having things in their mouth and chewing on things. So I still support pacifiers, but unfortunately not past 2.
Okay.
And actually, even 1.5 is a good way. I usually try to start them at 1.5 because they're not going to stop at 2 if they're like, if they need it. So you start to wean them off around 1.5. But I still do believe that is a pretty important tool to have for some children to help with the tactile and sensory portion. So up to 6 months, if you can wean them off after that, that's perfect.
Okay, great. And then our last and final, and I've tried to make any comments that were useful. I put them under the comments, and you're welcome to comment more there later. Teething tricks. I'm putting that on just because it's common. And speaking to people who think their baby's teething at 4 months, that's just so rare. They're very oral at that stage. So they have, and correct me if I'm wrong, kind of a lower jaw incompetency where they're not closing their mouth, the drool's happening, and they like to sense, like you said, their environment with their mouth. So they're not necessarily teething. And at that, so only once you actually feel the tooth at the edge, you really need to worry about calming the gum and soothing them, correct?
Yeah. Yeah. There's lots of teething toys and tools out there that you can use that are all very good. You know, if you want to add some more teething soothing options, basically you take those teething tools and you put them in the freezer. Or if you don't want to buy any, you know, we're all plastic free now per se, and they have silicone straws that you can put in the freezer and have the babies gnaw on them too.
So that's a great idea.
Yeah, or you can make popsicles that are out of breast milk, that the kids can that the infants can teethe upon and at the same time get nutrition. But you can definitely give them things to get through that teething stage. And the only time I would really give like our suggestion in terms of like medication is if they develop a fever. But beyond that, or if parents think they're pretty uncomfortable, but usually if you just give them a teething tool and add some frozen options to it, it should be pretty fine for the child. But you're right, every child's different, so maybe they need a little bit extra.
I just put some comments in there
Okay.
about my teething tricks.
Okay,
People can
perfect.
refer to them, but yeah, it's usually about something cold, and I like cold corn on the cob when they're really little.
Mm-hmm.
Cold carrots, frozen whole grain waffle or bagel, a frozen wash rag, celery, teething rings, and then when they're older, watermelon and things they can bite off that are soothing and cool in the gums.
Yeah, yeah.
And then if you do the popsicle, I like to wrap it with a paper towel and a rubber band so that when the baby's holding it, they're not going to get the frostbite. There is something called popsicle paniculitis where they do get these rash on their cheeks when they start loving the popsicles. So you have to be careful. It happens quite commonly when they're sucking on a popsicle for too long.
Yeah.
And take some time. But I love your suggestion about the silicone straws. And then there's something called sensory chew toys that you can look up on Amazon. They're for kids who like to do their nails or they're dirty. So you can get these fun, they're like plastic Lego pieces. They're probably silicone and shark tooths, other cool things. And the kids, they rip off easy so that they're not chokeable and the kids can put them in their mouth.
Yeah. Yeah.
So is there anything else you want to close with? I want to make sure everyone knows where they can find you at Smiles for OC.
Yeah. So, I thank you for inviting me today. And, these are all things that I'm passionate about that I would love for people to, understand and share with their own children. And as a mom now, I get it. It's like, it's awesome to be able to see it from the clinician side and the parent side. So, I'm super blessed that we've had that opportunity. But, I would take as many questions as anyone wants to email me or text me or come, if they want a consultation,
you mind back and I don't want to bother you for too much of your free time, but if you have a chance maybe later today to check the comments here and see if there's any new comments, that'd be great.
Okay. Yes.
Or you can let me know. I'll probably reach out to you actually, so I don't bother you. But so yeah, this is Dr. Christina Doe. This is the second of what I hope will be a long-term sticking event where we get to share our time with the public to correct misinformation that's always circulated in blogs that aren't verified and trusted resources. We are lucky to have plenty of time with our patients, but we know not everybody gets that. So we're glad to share what we can in this live stream. So thank you everyone for joining us. Thank you, Dr. Doe. I'm so lucky to know you.
Oh, I'm lucky
to know you too. And my patients are so grateful to when anyone I send your way, they feel so lucky to have you. So thank you for everything.
Yeah, thank you too.
All right. Take care.
Thank everyone for coming in. Yeah.
Bye-bye.